All right, let's start with ischemic heart disease manifestations. So, what do we have in this topic? So, the first thing we have is angina, right? What is angina? It's a chest pain due to ischemic myocardium, secondary to coronary artery narrowing or spasm, but there is no necrosis. Now, there are a couple types of angina. We have stable vasospastic, also known as Prince-Metal or variant, and unstable angina. So let's look at the stable one. Changing color. Stable angina. It is usually secondary to atherosclerosis, which is atherosclerosis greater than 70% of occlusion has to occur in order for someone to go into stable angina. Greater than 70% of the vessel has to be occluded. So exertional chest pain is there. It's in classic distribution, possibly with ST segment depression on ECG, which we will see here. Resolved with rest or nitroglycerin. The second variant is vasospastic Prince-Metal variant, which occurs at rest, secondary to coronary artery spasm. So it's due to spasm here, which causes transient ST elevation on ECG. Tobacco smoking is a risk factor, and hypertension and hypercholesterolemia are not. So what is the risk factor? Only tobacco smoking. Triggers are important. What are the triggers for this? There are cocaine, alcohol, triptans. And what are triptans? Triptans are, for example, dihydroergotamines that are used for migraines. They stimulate the serotonin receptor. So triptans are serotonin receptor stimulation through the dihydroergotamines. Okay. So what else you do? So you could treat this with calcium channel blockers, CCBs, nitrates, okay, and smoke cessation, because smoke cessation was a risk factor. So do the smoke cessation if applicable. The last one is just the changing color, unstable. Unstable means you have thrombosis with incomplete coronary artery occlusion. Here, incomplete is important. This versus your proper MI, myocardial infarction, if you just take a look, here you will have fully blown coronary artery atherosclerotic plaque, meaning 100%, not incomplete, but complete coronary artery occlusion will be seen in MI. Here you just have incomplete, not to 100%. Plus minus ST depression will be seen. T wave inversion will be seen on ECG, but no cardiac biomarkers elevation, unlike non-ST segment elevation MI, which is called NSTEMI. Increase in frequency or intensity of chest pain or any chest pain at rest. So there is increase in frequency or intensity of chest pain or any chest pain at rest. So now, important thing is now this table. So let's look at this table now. Here, what do we have in this table? So let's just change color and start with the first one, which is called stable angina. Stable angina, there's a pain on exertion. So just on exertion, you're going to have pain. Troponin levels are not high. And what are troponin levels? Well, in cardiac muscle, what do we have? We have enzymes known as troponin. So when you have the rupture of the cardiac muscle, for example, rupture of the cell membranes of the cardiac muscle, for example, in MI, myocardial infarction, or if you have damaged the cell, that cell leads to cell death, the cell membranes they get destroyed. So troponin comes out. When the troponin comes out, you will see that elevated within the blood, right? But here you stable angina, you're not going into infarction of a tissue, meaning death of a tissue. So you're not going to see any elevation of troponin. Not even in unstable angina, because remember, the unstable angina was just incomplete coronary artery occlusion. It is not fully complete occlusion, it's an incomplete occlusion, meaning blood is still going. When the blood is still going, you are not going to have a death of these tissue cells, leading to no troponin elevation. But in your NSTEMI, which is NSTEMI is for non-ST segment elevation MI and ST segment elevation MI. In these cases, because we're talking about MI, myocardial infarction, as the name suggests, the troponins will be high. We skipped the pain, so let's just go back to the pain here. Pain is about, on exertion, you're going to have pain with stable angina. With unstable angina, you will have, with mild exertion or even at rest, just think about at rest, you have pain at rest. And STEMI, again, pain at rest. And STEMI, pain at rest. Okay. Troponin levels, we talked about it. Infarction now. Infarction, you will not see any infarction in stable or unstable, but you will see infarction in your NSTEMI and STEMI. The only difference is in here, in NSTEMI, non-ST elevation MI is only subendocardium which is infarcted, meaning the death of the tissue is only subendocardial, which is mentioned right here. So if you recall, so let's say this is your heart, you have endocardium, which is just the first layer here. Then you have a bigger, thick layer called myocardium. And then you have this epicardium, right? So here we're just talking about this endocardium being infarcted, meaning death has occurred in these cells. Okay, and if you were to have the full thickness, full-blown infarction of the tissue, heart tissue, then you will call it transmural. Transmural means the whole wall thickness, right? So the whole wall thickness, as mentioned here, is going to be it will give us ST elevation on the ECG, and that we will talk about in ECG changes here. So what are the ECG changes? Well, in the ECG changes, what we'll see is in stable angina we don't have any ECG change. Unstable angina we might have ST depression or a T wave inversion. In NSTEMI we again would have ST depression and T wave inversion. But you say, hey, they're the same thing. Right, they are the same thing. So how would you differentiate this? So if they are the same thing, the only differentiation point is you then look at your troponins. The first thing you do is you look at ECG. You say, hey, wow, there's ST depression and T wave inversion. It might be either NSTEMI or it could be unstable angina. Let's look at the troponin levels. Draw the blood and look at troponin levels, and you will not see any elevation of troponin levels in unstable angina. But in NSTEMI or myocardial infarction, you will have elevated troponin levels, and that's how you differentiate these two together. And the last one is just as the name suggests, STEMI, ST elevation MI. So you will see an ST elevation. Okay, so that is what we have here. So let's just recall the whole thing. Move on to the next. For ischemic heart disease, we have angina. In angina, we have what is angina? Basically, angina is a chest pain. Why do we have the chest pain? Due to ischemia to the myocardium. Why do we have ischemia to myocardium? It is due to the coronary artery narrowing or spasm, in which case we would have spasm. That's only vasospastic Prinzmetal. Here is the vasospasm. All the rest is just coronary artery narrowing. Okay, and spasm. One important thing also is because you have increase in vagal tone, increasing. So these coronary arteries, they are very sensitive to acetylcholine. So there is in vasospastic angina, you will have increase in vagal tone that would give you increase in acetylcholine levels. That's important, high yield point. Increase in acetylcholine levels will be seen here. One more important point for this Prince medal is going to be that you will see this in young patient, okay, young patient less than 50 with minimal coronary artery disease risk factors, meaning there won't be any much risk factors, and on top of that, this patient will have recurrent chest discomfort. So recurrent chest discomfort, and it's going to occur at rest, especially at night. And why night? Because when you're sleeping, you have increase in parasympathetic activity. That increased parasympathetic activity indirectly means increase in vagal tone, which increases the acetylcholine, which causes coronary spasms. Okay, and these episodes are going to be spontaneous. So spontaneous chest pain with resolution within less than 15 minutes. Automatically resolute. You don't need nothing. It's just going to go away right away in 15 minutes. And he comes up and he's going to say, okay, the patient comes up with all of this. You do coronary angiography. Let's just say coronary angiography here, and you don't see any atherosclerosis, but he still has chest pain. So you think about vasospastic, and these triggers are very high yield: cocaine, alcohol, triptans, and also increase in acetylcholine, which is increase in vagal tone. So the whole treatment is all about, again, trying to fix that spasm, giving CCBs, calcium channel blockers, nitrates, smoke cessations, all of that. Okay, so that's all about vasospastic. Unstable, you're just looking at greater than 70% occlusion due to atherosclerosis, chest pain with exertion. Exertion is important. With unstable, you just have chest pain, incomplete occlusion with a ST segment depression, T-wave inversion, but without any elevation of markers. So no cardiac biomarker elevation. Okay, and it's going to be with even at rest. Now this table, pain, exertion, pain, rest. The whole thing is rest. Troponin levels, no elevation. Infarction, no infarction. Infarction is there. ECG changes, none. But here is the same, and here is also different. So because they're the same, you can differentiate it. Why these two things? Okay, moving on with the next one is called coronary steal syndrome. Coronary steal syndrome is distal to the coronary artery stenosis. The vessels are maximally dilated at the baseline. Administration of the vasodilators like pyridamole and regadenoson, right? They would dilate the normal vessels, which leads to blood is shunted towards well-perfused areas, causing ischemia in the myocardium, perfused by stenosed vessels, principle behind pharmacological stress test with coronary vasodilators. Okay, so first of all, what do we have here? This is dipyridamole is a drug that is PDE5 inhibitor. My bad, not 5-3. PDE3 inhibitor, and regadenoson is adenosine receptor agonist. Adenosine receptor agonist. Okay. So what is all this about? So this is simple. We're looking at coronary steal. So we have stenosis of the coronary blood vessel, right? So let's just draw this in order for it to make sense. So we have a coronary stenosis here. Distal to this part, which is coronary stenosis, vessels are maximally dilated. Okay, um, at the baseline, and why is that? Why are they dilated baseline, maximally dilated baseline? Because of the fact that when you have, if you recall, we did a hemostasis and we said, okay, blood needs to be in the organs, and organs have their own hemostatic hormonal systems which they secrete. So if there is no blood to the heart, what the heart does endogenously, it secretes nitric oxide and adenosine. And what are they supposed to do? Well, they are going to dilate the vessels. They are going to dilate the vessels distal to the stenosis. And administration of any vasodilator from outside would dilate the normal vessels. So when you dilate the normal, let's say this was stenotic, so you dilate it here endogenously, but you give some administrator from outside, which would dilate just normal vessels. So all the vessels are dilated. Now what's going to happen is blood is shunted towards well-perfused areas. Now, instead that the blood would go here, just like focus more on dilated part here, all of the arteries are dilated, so blood is just going to go in all of these dilated arteries. So the stenotic vessel, which was here, it's getting, first it was the main focus, right? The focused vessel was just one vessel, which was stenotic. Distal to the stenosis, you had this dilation, so it was trying to get more blood from all the source it can. But now since you gave from outside a vasodilator, now what's going to happen? All of the vessels are dilated. The problem with this going to be is that this vessel which needed the blood, now it's not getting sufficient blood. Well, when it is not getting well perfused as was already getting before. So blood is just shunted towards all of the areas which were already pretty good. So blood is shunted towards the well perfused areas, right? Now this leads to ischemia. Where? In this place. In ischemia and myocardium perfused by stenotic vessels. Okay, principle behind pharmacological stress test with coronary vasodilators. So this is what we do in pharmacological stress test, in which case we give vasodilator and see which areas are not having enough blood supply. And this is the principle behind a coronary vasodilator in stress test. Okay, so it's called coronary steal syndrome, basically stealing the blood, okay, from other areas. Then you have this sudden cardiac death. What is sudden cardiac death? As the name suggests, is a sudden cardiac death. Okay, here you just have unexpected death due to cardiac cause within 1 hour of symptom onset, high yield. Somebody has an unexpected death due to cardiac cause within 1 hour of symptoms. Most commonly due to lethal arrhythmias. Why did it occur in 1 hour? Arrhythmia. Which arrhythmia? Ventricular fibrillation. Right? Associated with coronary artery disease up to 70% of the cases. Cardiomyopathies, hypertrophic dilated, hereditary channelopathies, which are long QT syndrome, Brugada syndrome, presents with implantable cardioverter defibrillator, which will try to not let this happen, which is arrhythmia. And when this stops the arrhythmia, it's going to stop the sudden cardiac death. So in a nutshell, the sudden cardiac death is due to the fact that you're going into arrhythmia, but there are some associations with it, right? It's like already CAD, cardiomyopathy, something wrong with the heart. It was already there, which could be a CAD, could be cardiomyopathy, could be channelopathies like long QT syndrome, Brugada syndrome. Something was there that that caused arrhythmia, which caused sudden cardiac death within 1 hour of symptoms. And that's all for sudden cardiac death. The next one is about chronic ischemic heart disease. As the name suggests, it's a chronic ischemic heart disease. Well, chronic ischemic heart disease is a progressive onset of heart failure over many years, chronic, many years, due to chronic ischemic myocardial damage. Okay. So there, again, as the name suggests, what do we have? Because of this chronic ischemic heart disease, the patient is going to go into heart failure. So for many years, if any patient has this chronic ischemic myocardial damage, he can go into heart failure. That's the nutshell above. Now, there's another phenomenon called myocardial hibernation versus myocardial stunning. What is hibernation? Well, myocardial hibernation is potentially reversible left ventricular systolic dysfunction in the settings of chronic ischemia. So you already had a chronic ischemia, which was going to lead to heart failure, right? So now in hibernation, that left ventricular dysfunction occurred, but it is reversible. While with myocardial stunning, it's a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. Okay. So what do we learn from this thing? Well, we learned simple. It's with chronic ischemia, you can go into two sort of a thing. One thing is that it's going to go progress to the heart failure, as mentioned right here. Second thing is it can go into reversible left ventricular systolic dysfunction, which can again go back into the chronic heart failure, which is CHF, a congestive heart failure or heart failure. But it is reversible. It can be reversed if you fix the ischemia. But with the stunning, you just have a transient, because it's an acute ischemia, transient for a little bit, for the time moment that you have that ischemia, you will go into left ventricular systolic dysfunction. So that's what we have for chronic ischemia. Two things we got to know are myocardial hibernation and stunning in chronic ischemia. Then and one thing, make sure that we know that there is a left ventricular systolic dysfunction. So LVSD, left ventricular systolic dysfunction with chronic ischemia. Okay, that's all. And then we have this myocardial infarction, high yield topic. Myocardial infarction it is most often due to rupture of the coronary artery atherosclerotic plaque, which causes acute thrombosis, so complete occlusion, which causes increase in cardiac biomarkers. CKMB troponins are diagnostic. So we have two MIs. One is just the subendocardial MI, and one is transmural MI, meaning full thickness of the myocardium and only the endocardium. And subendocardial is called N-STEMI, which is due to the fact that we don't have ST elevation. We have ST depression. That's why we call it N-STEMI. And the other one is STEMI, meaning ST elevation MI. Now the layers involved, we talked about it, subendocardium and full thickness. Now one more thing that you will see is T wave inversion in the N-STEMI versus pathologic Q wave in STEMI. And that is all for MI. Some other things that we want to maybe look at are the risk factors for MI or any coronary artery disease. Diabetes. Diabetes is the worst risk factor. What is the most common risk factor though? It's not diabetes. Most common risk factor is hypertension. So we have a worst risk factor and the most common being the hypertension. And other risk factors could be tobacco smoking, dyslipidemias, in which case we have increase in LDL and decrease in HDL. And positive family history is also important. Positive family history. In which case we're looking at family history in the primary relatives, for example, parents, siblings with coronary artery disease. Okay, so these are all the risk factors that are for coronary artery disease. Now, what is this presentation of MI? So the patient will come with chest pain. Chest pain could be chest pain to a lot of things, right? So it is going to be specifically substernal, dull, sore type chest pain. Okay. And it will last for minutes. It will last for minutes and it will radiate to the lower jaw, the teeth, or the shoulder, left shoulder, or the arms. Okay. So left shoulder, arms, neck, lower jaw, anything. On top of that, this pain will be associated with shortness of breath, diaphoresis, and nausea. So this is the classic chest pain for MI. And that is all for MI. Now let's talk about the evolution of MI. So in the evolution of MI, what do we have? Commonly occluded arteries are LAD, RCA, and then circumflex. So what is LAD? Left anterior descending, RCA, right coronary artery, and circumflex is LCX, left circumflex artery. Okay. Here symptoms are again diaphoresis, nausea, vomiting, severe retrosternal chest pain, pain in the left arm or jaw, SOB, fatigue, shortness of breath, and fatigue. Okay, and what sort of pain? As we described, dull sore type. So they will not be able to point it. Let's say you say, okay, point the pain. That's very high yield actually. You say, point the pain where you have. If they're able to point it, okay, they say, hey, here's the pain. That's most likely not MI. They'll say, okay, they will just, hold the chest and says, it's here. I don't know where it is. It's a lot of pain. It's there. But they will not be able to pinpoint the pain. And we will see the differentials later on. Okay, then we have this, in the evolution of MI, all we have is from 0 to 24 hours. What do we see? So in grossly, what we have is the occluded artery. Wherever the occluded artery is, distal to that, we will see dark mottling, pale with tetrazolian stain. So just a dark color and pale. Dark mottling will be seen, as you can see in the picture, and also pale with tetrazolian stain. But in light microscopy, you will see wavy fibers wavy. Let me just change color here. You'll see wavy fibers within 0 to 4 hours, early coag necrosis within 4 to 24 hours would lead to cell content release into the blood, edema, into the blood. There will be edema and hemorrhage. Reperfusion injury is there. What is reperfusion injury? When the free radicals, when reperfusion injury lead to free radical formation and increase in calcium influx, which causes hypercontraction of myofibrils. So what is again reperfusion injury? That you already had this death of the cell in here, right? But if the oxygen was to return here, it will cause a reperfusion injury, in which case that oxygen will form free radicals. When it deals with the dead tissue, it forms free radicals. Those free radicals will cause more damage to the myocardium and will increase the CKMBs more, which is the protein comes out of the from the skeletal muscles and also the myocardial muscles. Why not troponin? Because troponin is already high, and we will see how troponin and CK they are different. Troponin will also come out, but they were already high. Okay, because of MI. So oxygen will return. That causes free radical injury. Okay, and with this, when the blood comes in, not only oxygen comes back, but also calcium comes back. When the calcium comes back, calcium is the activator for all the rest of enzymes. So when the calcium comes back, first of all, it's going to cause contraction of those myofibrils, and also it will activate more enzymes which are there. It will lead to more destruction. Also, contraction of the myofibrils. So that's the reperfusion injury. Okay, complications. Right away, you can have within any point within 1 day, you can have arrhythmia, you can have heart failure, you can have cardiogenic shock. Okay, that is what we will see within 0 to 24 hours, meaning 1 day. So now looking at actually look at this picture A. We didn't look at it. This is cell content released into the blood. So the cell contents are released into the blood, and you will see coag necrosis in picture A. Coag necrosis. Okay, moving on with this 1 to 3 days. That pale area is now hyperemic, with light microscopy showing extensive coag necrosis. It was just early coag necrosis. Now it is the extensive coag necrosis. And tissues surrounding the infarct show acute inflammation with neutrophils. And you know acute inflammation come with neutrophil, and chronic inflammation will come with macrophages. So we'll see that. But right away the neutrophils come, and you can see it in picture B here. Neutrophils arrive within 1 to 3 days. So, and the complication of this is post-infarction fibrinous pericarditis. Okay, so that is 1 to 3. One more thing here with the extensive coag. If you look closely here with the extensive coag, you will not see nuclei. So there is a loss of nuclei and striations in 1 to 3 days. And prominent neutrophil infiltration you will see here, which you have here, right? And these neutrophils, they cause fibrinous pericarditis, which is basically, pericarditis is a chest pain with friction rub. Chest pain with friction rub. Okay, now some more important things are the neutrophils. They are the border of the neutrophil will infiltrate first to the border of the injured tissue, which is the myocytes are relatively normal at this point, But secondary, what's going to happen, neutrophil eventually will move to the center and will cause the, will eat up the dead tissue and destroy more of the infarcted tissue. Okay. And this fibrinous pericarditis, which is post infarction, will only occur with a transmural infarction, because remember, you want to, if you are going into the pericardium, which is here, you have to have a transmural infarction so that neutrophils can go and form fibrinous exudates, called fibrinous pericarditis within the pericardium with a transmural inflammation. What is transmural? Again, STEMI, STEMI, ST elevation MI. So with the STEMI, you're looking at fibrinous pericarditis. Important thing, in 1 to 3 days, coag necrosis, loss of nuclei with neutrophils being there, starting acute inflammation, complication, fibrinous pericarditis. All right, 3 to 14 days. What do we see in 3 to 14 days? The macrophages, the big guy, the big guns, right? The big guns arrive by 3 to 14 days. Okay. Hyperemic. Now the border become hyperemic borders with central yellow-brown softening will be seen. Well, this is not that important, but here this about macrophages will come and they will start the granulation tissue at the margins. Picture C. So granulation tissue will start. It because they will phagocytose. What are the macrophages going to do? They will phagocytose anything extra, any dead tissue, anything they have. So they can lead to they can lead to rupture. So if they were to rupture the free wall, meaning let's say this is left ventricle, they rupture here, they will lead, it's going to cause tamponade. Again, you have heart muscle, and on top of it you have just have pericardium. So it will lead to tamponade. But if they rupture the papillary muscle, they will cause MR, mitral regurg. If they rupture, let's just draw it here one more time. If they rupture the interventricular septum right here, due to macrophage mediated structural degradation, it will cause left to right shunt. So shunt will start. So again, macrophages, the way you're going to think about it, by 3 to 14 days. So 3 days to about 2 weeks. The macrophage are going to little by little start eating the dead tissue, causing rupture of that dead tissue, wherever it was. Okay. And if it was infarction on the left side, the free wall, it's going to cause free wall rupture. Interventricular septal rupture. If it was in the papillary muscle rupture. Anything is possible. And then you have the left ventricle pseudo aneurysm. Okay, it's a pseudo aneurysm that can form, and that is also the risk of rupture, because the pseudo aneurysm that can also rupture. Okay, so this is within the 3 days to 2 weeks. Now you have 2 weeks to about months, right? And you will just, this is important now, gray-white scar, which is due to the contracted scar would complete in picture B, and you can see all of this is just scar. Let's just zoom in. Okay, so scar, contracted scar. Okay, now important point here is which connective tissue forms a scar. So which collagen, not connective tissue, which collagen would form the scar? So the collagen type 1 forms the late granulation tissue, right, which is the scar. And type 1 is also seen in where? In the tendon. I mean, all the other things, but on top of that is the tendon. So in 2 months to 2 weeks to months, you will see collagen type 1, uh, which forms a scar. Okay, that's important. Then you have this Dressler syndrome. The complication within 2 weeks to months is a Dressler syndrome is one. Then I don't know why they haven't mentioned it here, but let's talk about whatever they have mentioned. It's called post-cardiac injury syndrome, which is also known as Dressler syndrome. Okay, and then you have this heart failure, arrhythmia can occur. And why arrhythmia? Because now you have this gray white scar. It's just like this tissue it's on its own, right? It's not getting those action potentials from, let's say, stenoid and all that. So it can develop uh, electric charge here and can lead to arrhythmia. It's a complication. Okay, true ventricular aneurysm. So so pseudoaneurysm was on top. Here you have true ventricular aneurysm, which can lead to mural thrombus. Okay, why true ventricular aneurysm? Because the scar is not as strong, so aneurysm would form here, right? So when you're trying to contract, an aneurysm can form, and the blood will stay here. When the blood stays here, it can lead to thrombus formation, right? With the blood stasis. And now let's talk about this post cardiac injury syndrome, which is also known as Dressler syndrome. It is autoimmune pericarditis, in which case only occurs if there is a transparent inflammation, right? So the autoantibodies, so inflammatory cells will go into the pericardium, which is right here. So this pericardium, these inflammatory cells go to the pericardium, and the pericardial self-antigens gets exposed to the immune cells, and when they get exposed to this, they're like, hey, what is this fluid? It's an antigen. So they start making antibodies against it and causing an autoimmune destruction, which is known as post-cardiac injury syndrome, Dressler syndrome. Okay, so that is all we have here. But one more extra points that we need to know for 3 to 14 days are, you will see macrophages. On top of that, you will see granulation tissue. And neovascularization, you will also see neovascular, meaning new vessels will form, neovascularizations at this point. And also TGF beta will cause increase in fibroblasts, increase in fibroblast proliferation and migration at this point in 3 to 14 days. So macrophage is trying to eat the dead cells while the body is trying to make new blood vessels and trying to put the fibroblast so that they can proliferate, migrate, and also get the collagen type 1 and type 3 here, and that can lead to proper remodeling, which is called collagen remodeling, and formation of scar. Dense scar would start forming here. Okay. And that eventually what's going to happen is scar would form, and the scar will mature and will contract, and that's called fibrosis. Okay, that's all for this topic. So let's just review it and move on to the next. Okay, we talked about how evolution of myocardial infarction is in 0 to 2 in 1 day. Just call it 1 day. Within a day, you're gonna have a coag necrosis. Within a day, that you're gonna have you will have a reperfusion more injury, which will lead to hypercontraction. Arrhythmia, high yield. Within a day, you can have arrhythmia, heart failure, and shock. After 1 to 3 days, you're going in extensive necrosis with neutrophils being there. It can lead to pericarditis, fibrinous pericarditis. with 3 to 14 days, about 2 weeks now, 2 weeks in MI, we're looking at macrophages, granulation tissue, neovascularizations, fibroblasts, collagen depositions. We're looking at all sort of remodeling, collagen remodeling to form a scar. Okay, and this with the macrophage, you're looking at the rupture also, like free wall rupture, papillary muscle rupture, interventricular septal rupture, a pseudoaneurysm formation. With 2 weeks to months, we're looking at the proper scar formation, which is contracted, which has which matures and has contracted. And still here we can go into arrhythmias or post cardiac injury syndrome, Dressler syndrome, heart failure, and can also go into aneurysm, in which, because it's a scar, it doesn't have the property to relax and contract. So it can, if you push a lot through it, it's going to go into formation of aneurysm. Aneurysm, there is a stasis, there's a thrombus formation, and that is all for this topic.